Yeah, I think we'll just be starting in a minute or so, guys. And then Xiao Wei will take over.
So since it's 5 minutes past 6, I'll just start now. So today's tutorial is about collapse or loss of consciousness. They're all not always the same thing because you can have a collapse without losing consciousness. But we'll talk about this general theme in general. Yeah, in general. Okay, so we're gonna go through a case, and this is the general structure I'll be following. We'll just begin now with history. So this is a case of a 30-year-old man who comes to the ED and he's accompanied by a friend. He had fainted suddenly while they were on a walk together. So um, this is quite a common um, broad um, presentation of a collapse. And one thing to note is that you can also get a collateral history because his friend is there. All right, so could you just join this mentee and write some things about what your differentials you have in your head right now? The stem is this. I hope that's enough time, so I'll just flip back so that people can join the mentee. Okay, so we have 7 responses. I'm just gonna start looking at them. So we've got arrhythmia, syncope, the biggest one, narcolepsy, POTS, hypotension. So that's a really good overview of things. Syncope is a broad term that can have many different causes. We'll talk more about syncope and non-syncope. So not all fainting is syncope, basically. It's a specific term with a definition to it. Um, Arrhythmia is also something that can cause a sudden collapse. Um, for example, you might see someone with atrial fibrillation, probably a bit older, about 50 years old, and they might collapse when they go into AF. Um, Narcolepsy is a bit less common, so it is possible, but it's not like the first thing that you want to rule out. It's definitely not also in the top 5 differentials. Stroke is possible again, but it's also not a very typical presentation because usually you would have weakness in the arm and not really like a typical fall. Um, POTS and hypotension, they are kind of the same reason for falling. So when you stand up, you can have something called postural hypotension or orthostatic hypotension, and your blood pressure drops suddenly because your baroreceptor reflex doesn't work properly, and that causes a fall. And lastly, there's anemia, which is um, not really one of the things that I mentioned in when I made this set of slides, but it's true that anemia could cause you to be in a more susceptible state to have a fall. Um, okay, so this is a summary slide of all the causes of collapse. I know that it's a bit overwhelming, so let's just start with the difference between syncope and non-syncope. Syncope is caused by hypoperfusion of the brain, and anything else would then be non-syncopal. So the features of syncope would be that if you lie or sit down, you can restore perfusion to the brain and you'll feel much better. But in other things like seizures and hypoglycemia, uh, your posture doesn't really make a difference at all. So we're going into the different types of syncope here. It can happen via a range of mechanisms. Um, the common one that you might have experienced before even is vasovagal, which is for example when you're dehydrated or you've been in the sun and for a while and um, before you faint you feel some nausea, um, some warning of what's to come, and then you eventually collapse. And that is what is known as a reflex or neurally mediated um, type of syncope. I put a brain there for that reason. And of these, there are also other types, like a situational, um, basically a reflex. When the reflex gets triggered when you do a specific action, um, like when you sneeze, for example. And there's also carotid sinus hypersensitivity. So if you remember from preclins, the in the carotid sinus, there is some baroreceptors in the area, and sometimes it gets hypersensitive. So when you turn your neck, then it gets triggered. So cardiac and orthostatic. Cardiac arrhythmias, as I mentioned just now, AF. Some structural issues like a valve issue or cardiomyopathy can also cause the cardiac output to be compromised and that causes hypoperfusion. And for the orthostatic one, I've explained it just now. Um, and I'll move on to the non-syncopal ones now. So um, you can have epilepsy, which is in your neuro module, or metabolic causes, like in diabetes, if you go into ketosis, you might feel unwell. And Addison's disease can also cause you to be hypoglycemic. Um, something that might not be most exciting or in an SBA is alcohol intoxication, but practically it's quite common to see that. I think some lecturers say it's the most common cause of non-sickable collapse in the UK. It's not just alcohol as well. Other drugs or toxins can also cause you to have a compromised state of consciousness. Um, You can also have cataplexy and drop attacks. Cataplexy is associated with narcolepsy, as someone mentioned just now. Um, and these are just other head injuries that you can have. Infections can cause delirium and cause a non-syncopal collapse as well. And sometimes maybe the patient just fell, maybe they just tripped. So you need to get that really clear in your history. So you need to ask what exactly happened to get to the bottom of it. And yep, I put this picture here to remind myself to talk about how sometimes even in syncope, you might make a small jerking action just before you fall or during the fall, but it's not a full real epileptic seizure. So just be aware of that. You might be able to find some videos of on YouTube, but basically, um, if it's just very mild jerking, don't like make an assumption that it's definitely epilepsy. This is from last year's lecture, actually. I attended it and I found this mnemonic to be useful um, to remember all of that. So first you have pressure. This includes all of the reflex syncope I mentioned in the previous slide. You have arrhythmias, seizures, sugar, so basically like hypoglycemia. And then ouch is for trauma and head injury, urine for UTIs or other infection, and temperature, again, thinking about infection. Um, so if you're suspecting any of these infection things, you might want to bring in your knowledge from other parts of medicine and ask for that in the history. But we won't really be focusing on that today. We're focusing more on vasovagal arrhythmia, cardiac causes, and seizure. So what questions would you like to ask the patient now? Yeah, that's something you definitely want to ask, um, because it might provide some clues as to what's happening. Any normal history things that you like to ask? I mean, we have four people here. I'm expecting more. Any head injury, yes. So you ask for any injury, but head injury is the one that you want to know about the most. So other things would be like, did you fall on your hip? Does your hip hurt? Do you have a bruise there? Do you think you might have fractured something? Socrates, yes. It can also work for this. It might not be as relevant, but you always keep that structure in your head and it'll help you out. Did you black out? So basically, did you lose consciousness? And another way of asking that is to ask like, do you remember anything from what happened during the fall? So do you remember if there was someone beside you? Or do you have no recollection at all? Because that would be a true loss of consciousness when you completely just have a missing part of your memory. Um, how long was it for? That's also important. But of course, if they lost consciousness, then they wouldn't know. Then you want to ask his friend. Uh, any episodes of syncope before? Yeah, that is also helpful. Um, no, previous medical history, yes. Um, sometimes they have hypertension or and then they're on some antihypertensives, but if that works a bit too well, then they'll have postural hypotension. And sometimes it's also just like old people, their autonomic nervous system isn't as robust, so you can have hypertension and postural hypotension at the same time. But this is a good one to think about. Sometimes I'm just doing Jerry's right now, so there are a lot of things that can cause an old person to fall. They might have poor vision, they might be unsteady on their feet. Sometimes they're just sick with a flu and then they just are a bit weaker. Um, drugs and allergies, yes, that's always something you want to ask. Any palpitations or dizziness before the fall? So yeah, that's a question you want to ask to see if it's a cardiac cause. So really good. Um, so I'll explain it now. So we'll start with the structure. So as I said, Socrates works in this case, but it's not like the best for a collapse because you don't exactly ask like, so was it sharp or is it dull? So um yeah, before, during, after is the structure that we want to use. Um Okay, so sorry, I skipped ahead, but you would start with an open question like, so talk me through what happened, any idea what might have caused you to collapse. And from this, you just let the patient speak for a minute and you would get a lot of information from that. But if you want to go into the history of the presenting complaint, then you would like to know when exactly did this happen, how long did it last for, and did you have any other associated symptoms? Um, and I'll go into this before, during, after structure. As you said, yeah, anything in the past, um, any witnesses or video which would help you in diagnosing if it was a true seizure or not. How did they get to the hospital? Because you know, if they could call the ambulance, then then it probably wasn't that serious. Any resulting injuries from the fall, as I mentioned just now. So before the fall, you would want to ask if they felt anything unusual, anything that like made them feel like they were going to pass out. So what I've put here, flashing lights, strange smells, feeling of deja vu, this is the signs of an aura which would come before an epileptic seizure. Um, and for this other one, that you feel like going to pass out, lightheaded, nauseous, vision going black, sweating, feeling hot or cold. This is for vasovagal syncope. And these other symptoms, palpitations and shortness of breath, these are cardiopulmonary features. And sometimes, if there's no prodrome, it also suggests a cardiac cause. Um, and again, you would ask them again, what were you doing at the time? I'm not going to read all of these out, but these are just some things that you might want to ask. If you suspect a vasovagal from what they said, then you want to ask these clarifying questions that can help you verify your suspicion. And also, have you hit your head recently? Some people might have hit their head, but just somehow think it's not relevant, although it very much is, because any injury to the brain might have precipitated this incident. And during, you would want to ask, so how long did it last for? Have they actually lost consciousness? Um, so for the duration itself, if it's shorter, it's most likely to be um, syncope. And if it's longer, it's more likely to be a seizure. Also, I think, oh yeah, in a seizure, you can have consciousness or not have consciousness. Both are possible, so it doesn't really rule it out. Um, but it's just good to know, to verify if they actually lost consciousness. For epilepsy suggestive symptoms, so you just have to remember these red flags, yellow flags. Did they lose continence? So were they incontinent of urine or feces? Uh, did did they feel any taste of blood in their mouth after, or did the person next to them see that they were biting the tongue? Um, if it's on the side, it's more suggestive of epilepsy. If it's in the front, it's likely that the mouth just closed and then they just happen to bite the front. So it's not really uh, an epilepsy. Um, so yeah, did they have any limb jerking or any um, sudden stiffness or rigidity? And something that the GP told me was that it can also be quite informative to ask if they fell forwards or backwards, because in someone of our age, it would be natural to reach your arms forward to stop a fall. So it suggests that um, it's a mechanical fall and syncope, and you still have some consciousness present to stop the fall. Whereas if it's backwards, it's more likely to be something else. But it's not definitive. You can also ask the patient's friend if they have a video and if they can corroborate some of the other information that they might have, that the other person might not be aware of during the fall. And afterwards, do you feel drowsy or confused? And how long did it take for you to recover? So if it's less than 1 minute that they took to recover, it's most likely to be a vasovagal or syncope. But if it's a true seizure, you might have a post-ictal period in which you feel a bit confused and you take um, maybe half an hour to 1 hour to fully recover. So, do note that sometimes patients, they have recovered from a vasovagal, but they just don't feel well and they sit down for a bit, but that doesn't mean that it's a post-ictal period. So, you would have, if it's true post-ictal period, usually you are actually confused and drowsy, and maybe a part of your arms or legs is weak. Um, and that is called Todd's paresis, which is associated with a frontal lobe seizure. Um, and again, you would ask if they suffered any injuries during the fall. So we're going to talk about reflex syncope now. Um, it's a lot, so again, like, don't hesitate to put any questions in the chat. I know I'm talking quite a bit here. So reflex syncope is a neurally mediated form of syncope. As I said, the most common form of this is a vasovagal, especially in young people. Mm, And usually you would have a period of pre-syncope of feeling weak. I actually had this just this morning. I didn't actually pass out, but yeah, it was pre-syncope. I've been standing in the wardrobe for too long. So the four P's of vasovagal syncope that can help you identify one is a prodrome, a provocation, or a trigger. So can be pain, stress, anxiety, hyperventilation, or just dehydration or heat. Um, the posture, which means prolonged standing. Um, and yeah, you would recover promptly. less than 1 minute. So you'll be able to stand up immediately, even if you don't feel the best. Um, Situational, this is a bit odd, but sometimes if you have a coughing fit, sneeze, even swallow urine and strain on the toilet, you can trigger a reflex syncope. Um, and this is sick sinus syndrome or carotid sinus hypersensitivity. It is due to the stimulation of the carotid sinus baroreceptor. So I've actually seen a patient with this. It was quite odd. He was just like um going about his day, but he must have turned his head or something. And also another thing is when you shave, maybe like for a man, when they shave, they would tend to trigger it. And the way that they would test for this is um someone senior would do a carotid sinus massage. So just pressing here, and um you would see if you would trigger the same fall again. So obviously it's quite dangerous. So you would probably check using a Doppler or something to check for any clots, and then you would measure the blood pressure and heart rate during the trial to look for any bradycardia and fall in blood pressure that would indicate the reflex syncope happening. If the response is mainly bradycardic, cardiac pacing might help the patient. So the next one is orthostatic syncope, also known as postural hypotension. So it's defined as sorry, it's this is more of how to test for it. But the definition is like when you stand up and you fall due to a drop in your blood pressure. But the way that you quantify that with a lying standing blood pressure, after the patient stands up for 3 minutes, you observe a fall in systolic blood pressure of 20 or more, um, or it's only 10 or more, but it's symptomatic. So the patient maybe feels unwell, or you can have a fall in systolic, so sorry, the other one was a diastolic blood pressure, sorry. Um, so I'll start again. If you have a fall in systolic blood pressure of 20 or more, or a diastolic blood pressure drop of 10 or more, but it's symptomatic, or your systolic blood pressure drops to below 90. So you might have seen this on the wards, but you would get the patient to lie down first and then measure that. So that'll be the lying blood pressure, and then you get them to stand up for up to 1 minute or 3 minutes and see if it falls. And if it continues falling, you would want to measure it until it plateaus. So the risk factors for this happening is old age, also antihypertensives, and other medications that can affect your blood pressure, such as tricyclic antidepressants, hypovolemia. So maybe you have a loss of blood in some area of the body that you weren't previously aware of. Also autonomic dysfunction, so POTS should be in here, but also diabetes, Parkinson's are the more common causes of this. Alcohol and drugs can also interfere with your ANS. So finally, the rest of the history. So your past medical history, has this ever happened before? How was this the same or different? Is there anything that makes you more worried about this one than the past ones? Any past history of epilepsy, migraines, diabetes, heart disease? Um, Other risk factors. So these are basically um, cardiac risk factors, anemia, and psychiatric illness is for a psychogenic seizure. I would explain more about this later on when we're talking about seizures. The next one is a drug history. So, um, have you do you take any medications that interfere with blood pressure? And have these been changed recently? Because maybe the dosage is not suitable for them, which is causing this fall. Next one is family history of any epilepsy, cardiac problems, or early sudden deaths. So, in our OSCEs last year, I remember them asking, no, telling us that um, their father just had a heart problem. It was left quite vague, but that's something that you definitely want to flag up. Lastly, social history. So any alcohol, excess alcohol can also trigger a seizure. So that's one of the non-epileptic causes of a seizure. Um, can also have some cocaine use, which can again interfere with heart functions. Any stress at work or at home might also be something you want to take note of. So finally, we're coming to seizures. So a seizure is not the same as epilepsy. So a seizure is a episode, whereas epilepsy is a condition. So a seizure is a transient episode of uncontrolled excessive electrical activity in the brain, which may have some motor sensory or cognitive manifestations. Um, and anyone can have a seizure even if you don't have epilepsy. But epilepsy is a condition where you have seizures recurrently and without provocation. And a good thing to note is even in a diagnosed patient with epilepsy, there's a difference between a seizure that's part of the epilepsy and a provoked seizure that has other causes or triggers. So sometimes having repeated seizures can cause you to become um, epileptic, to have the condition of epilepsy, because like the changes that it causes if you're in your brain, it causes it to become more susceptible to seizures, and that causes the condition of epilepsy. So now that I've gone through that, what are some possible causes of a seizure that are not due to epilepsy? It's fine if you don't know anything. You can just guess from your experience. How does volume depletion cause orthostatic syncope? So, because there's less blood in your body, your blood pressure is going to be lower. So it's more likely that when you stand up, um, the blood pressure is below the threshold that is required. So you're more likely to have syncope, if that makes sense. So basically, volume depletion causes your blood pressure to be lower. Okay, so we have orthostatic, reflex, and drugs. Okay, so I think it might have caused some confusion. So orthostatic and reflex are causes of a syncope, but a seizure is non-syncopal, as I have previously mentioned. So if I go back to that slide, a seizure causes um your brain to have electrical activity that is abnormal, and this might be caused by certain um, changes in your body that make you more susceptible to a seizure. But a syncope is caused by hypoperfusion in the brain. So orthostatic and reflex are causes of like lack of blood reaching your brain. Oops. Alcohol withdrawal, yes. I believe it's called delirium tremens. So have if you're previously quite dependent on alcohol and suddenly you stop drinking, your brain might just react with a seizure. And I guess yeah, drugs might predispose you to a seizure. So looks like we don't really know basically. Um, okay, so there are so many causes of non-epilepsy causes of a seizure. You can have vitamin. So this is a surgical sieve that you can use to structure things. It's not exclusive to this. I've just chosen to put some structure into this. If not, it's just like a list of things. But basically, what you might let's just go into psychogenic seizures right now. So psychogenic seizures um are like dissociative spells. So you just it's part of maybe PTSD or something like that, where you just um look like you're having a seizure, but you're just really like out of it, dissociating for a while, and it can be really longer than the usual actual seizure, so maybe a few hours even. So that's due to a psychiatric cause. Um, Going back to the start, so a vascular cause might be hypertensive en encephalopathy, eclampsia, a stroke, AVM, or vasculitis. For the infective one, I would say UTI and delirium is the most important one that you need to know of. You can also have a brain abscess. Um, a traumatic cause would be head trauma and alcohol and toxins. So either drinking too much or withdrawing can cause a seizure. For autoimmune causes, as I've mentioned just now, vasculitis can play into this. For metabolic, hypoglycemia is the one that you should pay more attention to. But note that other electrolyte imbalances, such as low sodium, can also cause this. There can also be um, neoplastic causes, so any space-occupying lesion, like a brain tumor or the brain abscess, as I said just now, can cause the brain to react. Okay, so the psychogenic seizures, to elaborate, the way to tell is that psychogenic seizures are more likely to have these features. Um, you you would be able to tell with video and EEG monitoring, so that's where they put the electrodes on your scalp. Um, on the video, you would see pelvic thrusting, which seemed to be a feature common to psychogenic seizures, and also they're not fully unaware, so they might be able to respond to some commands, and because it's caused by a psychiatric issue, you would um it would be associated with some negative emotions or crying afterwards, and also it comes on gradually and lasts for longer. On the EEG, the brain activity would be normal, and it's not a true seizure because of that. And oh wait, yeah, it's not epilepsy because of that. Yeah, actually, this is not a seizure. I know it's under the heading of seizure, but traditionally it used to be called a pseudo seizure. Okay, so it might be treated with EMDR psychotherapy or any of those psychiatric um treatments. Okay. Stay with me for these few slides. There's gonna be a lot of information. Uh, but we're gonna start talking about epilepsy now. So um okay, so a seizure, how would you describe it? There are all these different terms you might see you being used to describe a seizure. We're just gonna go through it very slowly. So tonic-clonic gremol is the one that you have probably heard of or seen on a TV show. Um, as the name suggests, you have tonic and clonic. So tonic is where you have the stage of rigidity, stiffness, as you can see in this picture here. The back might be arched because of the increased muscle tone. The respiratory muscles might also be affected, so you can't breathe properly, so you might become cyanotic. Because of the smooth muscles of the bladder not working properly, you can also have incontinence. Um, so they'll have this phase, but they'll also then switch to a clonic phase, with sustained convulsive rhythmic contractions, followed by relaxations, and this can last up to 2 minutes. As part of this, you can also have tongue biting. So you can see a picture of that up here. So that's a grand mal seizure where you have both phases. And you can also have a preceding aura, as you can see here. You can also have flashing lights, nausea, sensory changes, and hallucinations as part of this aura. And afterwards, you would have a post-ictal stage. So really, these stages are more for this seizure. But you can also have a seizure that only has a tonic phase or only has a clonic phase. And some of the types of seizures is absence seizure. It's more common in children where they are just completely vacant and unresponsive for up to 30 seconds. So you might be talking to them and then suddenly they're just gone. But then after a few seconds, then they come back and then they'll be like, what happened? Um, no, you would you would be puzzled at what happened, but they would have no recollection of it because they lose consciousness. So to them, nothing has happened, and the last few seconds didn't happen. The next one is atonic. So your muscles become limp, and because of that, you fall to the ground. Right. So the next one is a myoclonic seizure. I know it sounds like a clonic seizure, but it's shorter and it's more of a jerky like spasm, muscle spasm, whereas this is repeated contractions and relaxations. Okay, and one more, oops, is cataplexy, which might mimic an atonic seizure. Um, this is the one that I said is associated with narcolepsy because two-thirds of patients with narcolepsy also have cataplexy. And with this, it is also a loss from all muscle tone, um, but they always remain fully conscious, and it might be preceded by a strong emotional stimulus. So usually in questions, this would be um, laughing a lot or being frightened, and after this emotional stimulus, it triggers the loss of muscle tone. So it's not an epilepsy, and it's instead a muscle paralysis. And the reason why it's linked to narcolepsy is because it's similar to the muscle paralysis you have in REM sleep, which is interesting. Okay, um, next bit you have to know about epilepsy is um, the part of the brain that it affects. So it can be focal only in one side of the brain, or it can be in both hemispheres. So that's a generalized seizure. Um, a primary generalized seizure would have started in both hemispheres right at the start, whereas a secondary generalized seizure might have started off as focal and then eventually spread to both sides. And the way that this presents differently is that um, a generalized seizure, you always have loss of consciousness, whereas with focal, you could or you could not. Both are possible. With the symptoms in a focal seizure, if it happens in different parts of the brain, there are different symptoms that are characteristic of each part, and that will be what I'll explain. I'll explain in the next slide. But for now, just know that. Um, and for a generalized seizure, usually it only presents as tonic-clonic or tonic and clonic and atonic. And if it's a non-motor seizure, it will be an absent seizure. What's missing from here is a myoclonic seizure. And with a generalized seizure, you would typically always have an aura, whereas for focal, it's not really um, there usually, like, unless it's a temporal lobe seizure. So now we have an activity. Could you try to match a frontal lobe seizure to um, whichever set of symptoms you think matches it the most? Oh, so a focal seizure is when um it starts in one hemisphere of the brain and then it only stays there. Whereas a secondary generalized seizure would be one that changes from a focal seizure to become generalized as part of the course of um the the seizure. No worries. So I'm not sure what's going on with this. Can you use this? Oh, okay. Let me try to troubleshoot this. Mm. Hold on, I do see some responses. So what I want you to do is to, I'm gonna reset it now, but can you put the pin on which set of symptoms you think is applicable to um a frontal seizure? Mm. Sorry, just give me a minute. Um, I've reset the slide now. Is it working? Okay, I see some responses. Let me just start sharing my screen again. Hey, we're back. Mm, so I I think um what you guys have selected is not frontal. I think it's parietal. Yeah, because so this is more of a sensory issue. Um I know I tripped you up a little with the kept touching my leg bit. But it's not a loss of motor control, but sometimes if your leg feels weird, you would try to touch it. So the part that was, yeah, that's the correct one. That's a frontal seizure. So a loss of motor control and a Jacksonian march from the fingers up to the arms and the shoulder. So for this one, the leg feeling like they're not part of your body, feels like some outside thing that doesn't belong to you. That's quite common in a parietal seizure. Um, Going to try to reset this now. And now we're going to do the next one, which is a temporal lobe seizure. Yeah, from what I'm seeing, that's correct. So a temporal lobe seizure is associated with emotions and automatisms, like smacking your lips. And for the last one, Um, the one that we haven't done would be the blinking lights and colors. So that's occipital lobe. I'm gonna just go through this and how it makes sense to me. So a frontal lobe, it contains the motor cortex, sorry. And so it makes sense that there's a loss of motor control. And for the parietal one, it contains the somatosensory cortex. So then it makes sense that there are sensory abnormalities. And for the temporal lobe, there's the hippocampus and all the other um emotional, I mean, yeah, emotional related things. So again, it makes sense that you have emotion related symptoms and um, hallucinations is quite an important one as well. Uh, this epigastric rising thing, um, just know that in a question, whenever they say there's a weird sensation in the tummy, something going up, then you know it's a temporal seizure. Um, Lip smacking and clothes plucking, any repeated action is also suggestive of that. And for the occipital seizure, it makes sense to me because the visual cortex sits right here. So uh, visual abnormalities and the loss of vision, um, yeah, will be associated with occipital seizure. And again, these are focal seizures. Only with focal seizures you have such like specific symptoms. So finally, a summary of what we've gone through. With an epilepsy, yeah, um, it's possible to have a aura, but it's also possible to not have an aura. It's confusing, but you still have to ask about aura symptoms. Um, vasovagal, you might have a preceding presyncopal experience, so like nausea, um, lightheadedness, and with arrhythmia, there's no warning, but with other cardiac causes, um, it's still possible to have palpitations and shortness of breath. And um, I mean, I think we have gone through enough of these, so you can look at these in your own time. But do ask me if you have any questions. Okay, so this is the first SPA for today. I'll just let you have about 1 or 2 minutes.
Hi, I'm really sorry to interrupt. I think you're muted.
Oh, I'm so sorry. Okay. I'm gonna repeat all of that. So I'm sorry for making this really hard. This I made it hard deliberately for your learning. With narcolepsy, it'll be associated with cataplexy, but in this case, there was no mentioned emotional stimulus, so it's unlikely. Um, with a tonic seizure, I think you'll understand that because she was motionless, it's not likely. With a vasovagal syncope, you would likely recover much quicker than 2 hours. Being unable to concentrate on a work suggests some sort of drowsiness that is not really in keeping with a vasovagal syncope. And with cardiogenic syncope, you would also recover really quickly, probably immediately. And that's why the answer is atonic seizure. So in this case, she lost consciousness and um, had a 2 hour post-ictal period. So that is correct. And that's the last part of the history. Now we're going to examination. Again, another Mentimeter. Could you just rank your top differentials for our 30-year-old man, given all these additional details that I've given you up here? Oh, okay, it's coming up now. Um, gonna try waiting for one more response, maybe. Um, so all these um they're not hmm, they're not wrong, but also I would put vasovagal as the first one, just because that's the most common cause in young people. For orthostatic, you wouldn't really look for in a young man because usually that's because of autonomic dysfunction, which is more common in elderly people or people with cardiac risk factors. So that would usually be middle age and above. Um, and for hypoglycemia, I guess that's because you suspect that they might have diabetes that's been undiagnosed. Um, um, I would still put that below vasovagal, if that makes sense. Um, yeah, so now we're going to talk about like how this changes if the patient was older. So it's mostly just the reverse of what we've done just now. If someone can just put in a quick response. Yes, that is correct. So orthostatic you would be more concerned about, and cardiac can also be a bit higher because you could have arrhythmia or even an MI that could trigger um, a collapse. Mechanical fall is also one because maybe they're unsteady on their feet for one reason or another. And it is true that vasovagal syncope is prevalent despite the age. So one more question. How would you like to examine this patient? So from a systems point of view, we've talked about um, different causes of collapse. So what are those causes? Which symptoms are they linked to, and how can you examine them? I really don't need like a very in-depth answer, just some phrases, some words. Cardiovascular, excellent. So that's one of the systems. It's another system that you might want to examine. No? Okay, so we just move on now. Bloods. Yes. So that would be after the examinations when you're going to the investigations. Neuro exam. Excellent. That is what you want. A neuro and a cardiovascular exam. And also some specific signs of epilepsy that you want to check for. So that would be tongue biting, trauma, basal skull fracture. Might want to look into the signs of basal skull fracture. I think it was raccoon eyes and the battle sign. Um, Also, any signs of dehydration, dry mucous membranes, tachycardia, or hypertension. Going back to the cardio and neuro exam, I'm not gonna go through them too much because I think you know what they are about. But the particular parts that are most important and relevant to this would be the lying and standing blood pressure, an irregular pulse for AF, and bradycardia for heart block. Um, any murmurs or that would indicate some valvular disorder. For neuro, you want to look for post-ictal features, so maybe they just presented after a possible seizure and they still have some remaining limb weakness or sensory deficits. You might be looking for some signs of autonomic dysfunction. If they have signs of Parkinsonism, then you would know that they have problems with autonomic dysfunction. Any peripheral neuropathy as well, any sensory deficits around the body that might indicate that they have diabetes that's severe enough in its stage that it interferes with their neural system. Um, and also for external injuries that might occur for as a result of the fall. So I was just looking at this diagram of seizure-related injuries because people can't control what they're doing is during a seizure. Um, a huge proportion of them have head injuries, or water immersion. I think like falling into a body of water, burning themselves. So because of this, you want to look for head trauma, lacerations, fractures, and if there's any suspicious joints, you would like to examine them. So finally, we've come to cardiac syncope. I think this should be the last big chunk of information. So this occurs due to a decreased cardiac output. Reminder that cardiac output refers to a stroke volume multiplied by heart rate. And as a result of this reduced cardiac output, there is hypoperfusion of the brain, which results in syncope. And the decreased cardiac output is usually from a structural or rhythm abnormality. So if it's a structural abnormality, you would usually see it on an echocardiogram. And if it's a rhythm abnormality, you can detect that using an ECG. And the reason that I mentioned palpitations and shortness of breath and all that that might happen before such an event is because sometimes it's caused by a low flow state where after you exert yourself, then it causes it precipitates an episode of further decreased cardiac output and cerebral hypoperfusion. So the causes are quite varied, but this mnemonic might help. So H for heart attack, like an acute MI, embolism, like a massive PE, like a saddle PE that might cause disruption in your cardiac output. Aortic obstruction. Remember that syncope is part of the SAD's acronym for aortic stenosis. HOCM is a congenital disease that I'll explain later. An arrhythmia, generally, if the heart is not contracting in a in its usual way, I forgot the word for it, but if it's contracting irregularly, then it makes sense that the cardiac output is not optimal. As for tachycardia, if your heartbeat is too fast, there's not enough time in between the beats for the heart to refill properly and have the right tension to continue pumping out the same cardiac output. So the features of this, it's either a sudden collapse with no warning and recovering very quickly, or if it's a low flow state or cardiopulmonary cause, it can be exacerbated by exertion. So what you would see is the patient collapse after exercising a lot. So maybe they were on a treadmill and they felt unwell. And the parts of the history that you want to look out for is also a past medical history of cardiac disease and risk factors, and maybe a family history of cardiac issues, heart issues, that can include arrhythmias, Wolff-Parkinson-White or Brugada syndrome. These are a bit niche. You don't really have to know them, but you do need to know about HOCM. So, what is that? It is hypertrophic obstructive cardiomyopathy, but I believe the newer term might remove the word obstructive, so it's just HCM. But they both refer to the same thing, where it's a congenital, autosomal dominant, inherited disease. It has variable penetrance, which means it can vary in severity between different people, but in the most severe cases, you can have sudden cardiac death. So how it works is that you have hypertrophy in the septum or in the left ventricle, and as a result of this, you can have an obstruction in the ventricular outflow. So the wall itself is so thick that it obstructs blood from exiting the heart. And these are just some keywords that I wanted to show you in case you recognize it in a question or in a pathology report, then you can recognize this condition. In a cardiac examination, it might present as an ejection systolic murmur, just like a aortic stenosis, or you might have mitral regurgitation, which is a bit rarer, but it's still possible. So now that we're done with HOCM, just wanted to quickly revise an AV note block or heart block. So the ones that are more relevant here are second degree Mobitz type 2 blocks, because they have a high risk of progressing to a complete heart block, where the P waves are completely unrelated to the QRS complexes, which means the atrial contractions are completely unrelated to the ventricular contractions. And as a result of this, it severely impacts the cardiac output. So there's also a high risk of asystole, which is where the heart does not beat at all. And that's why you can have syncope or just sudden cardiac death. The way you would treat this is with a permanent pacemaker. So this is the first one, AV node block, which is what people are referring to with heart block. But there's another one, which is a bundle branch block, which would also cause compromised cardiac output, but it's a little bit different because you have the William Marrow sign in your ECG. And if you want to look into this even further, there is bifascicular or trifascicular heart block. But because of time concerns, I'm not gonna go through it right now. But just so you know, the left bundle branch it splits into two different fascicles, and that's why you have this. For the William Marrow thing, I don't really recognize when there's a W. It's never made sense to me, so I really just look for this sign, which they call the R prime complex. So hope that helps in differentiating the different types of blocks. And this is really hard again, but just try your best. What is this ECG abnormality? What is your best guess? And a hint is that it's related to what I've just gone through. I'll give it a minute, and if nobody has responded, I'll just go through it. Oh, there is one response. Left bundle branch block. So that would be William, which would be, yeah, there's no real RSR complex here. So I wouldn't say a left bundle branch block. So this is a third degree heart block, which is because the P waves are not associated with the QRS complexes at all. If you look carefully, these are the P waves. They're pretty consistent and they're not related at all to the rhythm of the QRS complexes, which are regular but kind of in the other alternate world. So yeah. Investigations. What investigations should be carried out in this case? This would be the second SPA. I'll give it a minute and I'll show the answer. So it's a loop recorder. This is because this suggests an arrhythmia that might be intermittent, and that's why we want to record for a longer period of time, longer than 7 days. This is typically a minor procedure where they go under the skin and they implant a loop recorder physically and see if they can detect any arrhythmias. Before this, can the two of you remaining just fill in the feedback form? It'll be really helpful, and I'll give you a minute or two. Just tell me if you have completed it. I'm sorry, could you just like indicate if you've completed it? Okay, thank you for that. I'll move on now and I'll go into the investigations. So the general structure you want to use for investigations is bedside, bloods, and imaging. So with bedside, the basic obs as usual, that's blood pressure, heart rate, respiratory rate, also ECG. As I said, there are various options for long-term monitoring. That can be a 24-hour ECG or an implantable loop recorder. You can also do a capillary blood glucose, which is actually one of the key things you want to remember for collapse. So that's the test for hypoglycemia, usually below 4 you will be concerned about. Lying and standing blood pressure, as I have mentioned just now. For the bloods, you would do full blood count, use an ease. Always remember to justify why you're doing that set of bloods. A VBG is also relevant because the raised lactate might follow a seizure or cardiac event due to the ischemia that it causes, and CRP for infection. For imaging, there's something called a tilt table test, but I've practically never seen this happen, but just know that it's something that you would do for vasovagal or orthostatic. I think they tilt the table and then they see if you pass out, basically. Um, for a seizure, I just wanted to emphasize that these investigations will only be done by a neurologist. So if you are just a GP, you would not be doing them. The diagnosis of an epilepsy or seizure would be done by a neurologist. So refer them to a seizure clinic and then see what goes on after that. For head trauma, you always want to do a CT head. And this is a general infection screen, just like looking for infection everywhere possible. Cardiac, you would do an echo, cardiac MRI, or even a carotid sinus massage if you want to suspect a sick sinus. And also a drug screen might be relevant if you suspect that based on the history. But again, you won't do all of this. Maybe these you would do for all of them, but for these you would do them based on the history and the causes that you suspect in that particular instance. So finally, for the management, so you've looked at the blood pressure and you might find that this does not correspond to an orthostatic syncope because the drop is not big enough. So what you would do now is you would not do anything else, because if it's a vasovagal and there's no other worrying signs like any ECG changes, there's nothing to be done. And all you have to do is to reassure the patient and give some lifestyle advice. So sit down if you feel faint, drink water, avoid all of these situations that might trigger syncope. And for an orthostatic syncope, you might want to advise them also on hydration specifically and salt intake, because salt is the thing that actually keeps liquids in your water in your body. I also want to ask for a medication review if they are on many different medications. There's also something called a counter pressure measure, which is gripping your hand like this, really hard, pulling as hard as possible, which can maintain your blood pressure. Because I have compression garments or fludrocortisone and midodrine. Again, this is quite niche. Cardiac syncope would be quite simply referring to cardio for review. For DVLA, you would say that you can't drive for 6 months if you don't know what it is, unless it's a uncomplicated vasovagal, which is so common. So then there's no DVLA rules for this. So for seizure specifically, you need to explain. So this is possible to come out in an OSCE station for a seizure. So counseling a patient on what to do after their first seizure. So because there's only one seizure, you would say this is not epilepsy, don't be worried. And it's more likely to be an underlying cause. So for example, they might have drank a lot of alcohol, just for example, and then you would refer them to a neurology first seizure clinic. And because if they have had one seizure, in case it happens again, before they know the diagnosis, it's best to stop operating heavy machinery, working at heights, don't take baths, don't go swimming, uh, for drowning risk, stop driving. And again, I'll show the rules in the next slide. Avoid triggers such as these. And you might want to counsel them on what to do if the seizure occurs again, because it can be quite scary if the people around them don't know what to do. The most important thing I would say is to time the episode. So once it starts, you want to start the timer, and if it lasts for more than 5 minutes, then it's a status epilepticus, and you would need to call an ambulance for that. Or you start another seizure without regaining consciousness from the first, and the entire duration of that is more than 5 minutes. And also don't restrain or move them. Don't put things into their mouth. If they bite the tongue, just let it be. But you might want to move sharp objects, hazardous objects away from them. You can also put soft things like pillows or blankets around them. So the rules for seizures, they might look intimidating, but the general rule is that if you have your first seizure, don't drive a normal car for 6 months. And if you've had multiple seizures, then that increases to double, so 1 year. And if you're driving heavy vehicles like buses or trucks, then multiplied by 10. So if it was first seizure, then it becomes 5, and it was multiple seizures, then it becomes 10. Um, and you also have to make sure that the patient is notifying the DVLA. If they don't want to, you have to be the one to do it. Yeah, and they should continue taking anti-epileptics and keep up with the therapy. So this is just a big slide about the anticonvulsants that can be used to treat epilepsy. Note that there can be different options for males and females, because while all of them are teratogenic, and some of them have a lower risk, such as lamotrigine and levetiracetam. So that's why valproate will be prescribed to males, whereas these will be prescribed to females. And for a focal seizure, you would have lamotrigine and levetiracetam, and you would not use valproate. For the absent seizure, you specifically need to use isatuximide. For tonic and atonic seizures, it would be lamotrigine specifically for females, and then for myoclonic, it's levetiracetam. So the way I remember this was a race is like a movement, so myoclonic seizures would be indicated, whereas the tonic or atonic, there's no movements, so it's not race. So it's lamotrigine. And I believe this is the final slide, but these are just some side effects that you want to take note of. I'll just leave it up here because I'm aware that there's been a lot of information today. Maybe just know that for carbamazepine and agranulocytosis, the impact of this is that when you're counseling a patient about starting the drug for the first time, you want to say that if they have any symptoms of an infection, like a sore throat, a fever, they have to come to the A&E just to get full blood counts and check if their white cell count is low. So yeah, that's the end of the presentation. Please ask any questions if you want, and fill out the feedback form if you haven't. Oh, no worries. I'm glad to hear that's been helpful. I'll also stop the recording now. Let's see if I can, yeah.